Did you know that about half the people with bipolar disorder spend more time in one phase over the other? And which phase that is can make a difference in how well you do? I'll explain. I'm Dr. Tracey Marks, a psychiatrist, and I make mental health education videos. Bipolar disorder is a mood disorder where you have episodes of depression and separate episodes of mania or hypomania. You can watch other videos that I'll link to this one that give details of the symptoms of mania, hypomania, and depression. The disorder is called bipolar because you experience symptoms at opposite end of a mood spectrum, like north and south poles. The two types of bipolar disorder are type 1, where you have episodes of depression and mania, and type 2, where you have episodes of depression and hypomania. Within both of these forms of the disorder, you can also have a mixed type where you have a combination of depression and mania happening at the same time, or a rapid cycling type where you have 4 or more separate episodes in a year. That's a general overview. Now here's the newer information. Not everyone experiences bipolar disorder in the same way of switching back and forth between mania and depression. About half of the people with bipolar 1 or 2 spend a predominant amount of time at one pole over the other. This is called predominant polarity, and it's defined as having at least twice as many episodes of one pole over the other. Here's what it can look like. If you are depression polarity predominant, or DPP, chances are your first ever episode was major depression, and you probably had a few depressive episodes before you had a manic or hypomanic episode. Because you started with depression, it would not have been obvious at the beginning that your depression was part of bipolar disorder. So you may have gone years being treated as unipolar depression with antidepressants only, but the standard treatment for bipolar disorder is a mood stabilizer first. So many times the person who shows up with unrecognized bipolar depression and gets put on an antidepressant may not do well on the medication. Antidepressants tend to make bipolar disorder worse by triggering rapid cycling or creating mixed episodes where you have this awful, agitated depression. I say antidepressants tend to do this because it's the trend, but it's not an absolute. Some people with bipolar disorder can tolerate small doses of antidepressants as long as they are also on a mood stabilizer. For a minority of people, the antidepressant is the only thing that elevates their mood. Nevertheless, the recommendations are to still use mood stabilizers to treat the depression episodes. But admittedly, our antidepressant treatment options are not as good as the anti-manic options. And this is why people with the depression predominance tend to spend more time not feeling well. Some people with the depression predominance can have cycles of depression followed by mania and then an interval with nothing going on. But at some point, they will have back-to-back depressive episodes such that they may forget that there ever was a manic episode in the past. In fact, forgetting about the mania can be another reason for a worse treatment outcome. Let's say you have a hypomanic episode and your doctor adds a mood stabilizer to your antidepressant. You do well for years on this regimen, except for a few periods where your mood dips and then it recovers. You switch insurance and get a new doctor. Your new doctor gets your history and you tell them about your depressions and forget the time when you were hypomanic because it was years ago. You've gained a lot of weight from the Abilify that your doctor added back then, and together you and your new doctor decide to get rid of it. Your new doctor doubts that you have bipolar disorder because they didn't hear much about the mania when you were talking to them. And so now they start treating you for unipolar depression. Months after stopping the Abilify, you get more depressed. Your doctor adds a new antidepressant, which triggers a mixed manic state. Now things are a mess, and your doctor has to scramble to get you out of that state. Unfortunately, this situation is all too common. But let's look at the other pole. People who have the mania polarity predominance, or MPP, usually present with their first episode as mania. So it's obvious from the start that this is not unipolar depression. People with mania predominance also tend to have their first episode at a younger age, like late teens or early 20s and tend to have more psychotic symptoms with their mania or depression. The main psychotic symptom is delusions. If it's a manic episode, the delusions tend to be grandiose or religious. Going naked in public while manic is a thing. If you're in the depressed state, the delusions tend to be more persecutory, like someone is out to get you. A person with mania predominance can have the classic pattern of mania followed by a depression crash or back-to-back mania. Even though mania tends to be more destructive, creating a devastating path of bad decisions and negative consequences, from a treatment standpoint, mania is much easier to treat than depression. Why? Because the antipsychotics we use as mood stabilizers are much better at slowing down mania than they are at lifting someone out of a depression. So being manic is scary because of the unpredictability of your behavior, but the good side is if you stay in contact with your doctor and have family or friends keeping an eye on you, you can catch the symptoms before they spiral out of control, making the treatment outcomes better for people with the mania predominance. Now, there are people who don't have a predominance of one pole over the other. You may have the more classic pattern of alternating episodes. You can have depression, then mania, then an interval with neither, and that interval can be months to years, and then you get depression again and the cycle repeats. Why does it matter to know all of this? One way it can help is in your medication choice. There's some research and development that looks at rating medications by their tendency to do better with mania versus depression and developing an algorithm which you can use to choose the medication based on the person's polarity predominance. This polarity index is called, isn't ready for general use yet. It still needs some more studies to show that it works consistently. But we do have some ideas about which medications are supposed to work better for bipolar depression, whether you're depression predominant or not. Most of the medications work well for mania, but it's the depressed phase and mixed symptoms that are more of a problem. I have a handy guide that tells you what medications are FDA approved for what phase of the illness. I'll have a link in the description where you can download it. But I'll go ahead and say for now that quetiapine, or Seroquel is the brand name, Vraylar, Latuda, and the new Caplyta are FDA approved for bipolar depression, and lamotrigine is not FDA approved for bipolar depression, but in practice, it's used a lot for this purpose. So if you are depression predominant, you may do better on one of these meds. For the person who is mania predominant, you should be especially careful about taking an antidepressant when you slip into depression. Remember I said that some people can get by with a little bit of an antidepressant added to their mood stabilizer to get them out of depression? That's probably not you. If you are mostly manic with infrequent depressive episodes, an antidepressant is more likely to flip you into mania, a mixed episode, or send you rapid cycling. What can you do then if you get depressed? Your doctor can add another mood stabilizer or add lithium if you're lithium responsive. Not everyone is. I have a video talking about that called Classic versus Atypical Bipolar Disorder. Another thing that you can do is light therapy. There's a modified protocol for bipolar disorder, and I have a video on that too. If your bipolar disorder is a new diagnosis and you don't have enough of a pattern to establish a predominance, it's time to keep a mood journal. It doesn't have to be anything fancy. You don't need to journal your mood every day. You just need to keep up with your mood episodes. If you had a depressive episode in March 2020, write it down and write down how long it lasted. You don't need to be exact. Was it weeks or months or years long? Then the next time you have another episode, and we're talking about symptoms that last at least 2 weeks for depression or a week for mania, write down the month and the year that you have that. Then at some point, you can get a bird's eye view of how many episodes you have in a year, which pole you were, and how long your episodes typically last. Now, I realize episodes are painful, and this is probably not something you want to keep up with, but you don't need to meditate over it. You just need to note it for reference later. If you change doctors, this kind of information will be super helpful for a smooth transition. And if there's a pattern to your episodes, the information can help inform your doctor of what medication to prescribe if you're not responding well to your current regimen. Take a look at my bipolar playlist for more on bipolar disorder. And if you like having written information, check out my bipolar handbook. It's one of the items in my merch store. Thanks for watching. See you next time.